Hello and welcome to Single Pair Radio. I'm Paul Hoppe, broadcasting from the Hayburn Building in Louisville on the WFMP 106.5 Forward Radio Community Network, where news, information, and entertainment is available 24 hours a day, 7 days a week. The views and opinions expressed on our show are those of the speakers and not the station. Single Pair Radio is a project of Kentuckians for Single Pair Healthcare, in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded single-payer healthcare system, commonly referred to as Enhanced Medicare for All, covering dental, vision, hearing, prescriptions, and long-term care, covering everyone starting at birth. Catch our programs at 2 p.m. Monday, 7 a.m. Tuesday, and 11 a.m. on Wednesday. We also stream our show on SoundCloud so you can listen anytime. This radio station relies on volunteers like me and your ideas and donations to keep us on the air. Today, Drs. Mike Flynn and Gene Shively join me as co-hosts with their special guest, so let's jump right in. Dr. Flynn?
Well, thank you. This is Michael Flynn, retired surgical oncologist from the University of Louisville. Surgery department, let me begin with the usual disclaimer. Any comments I make represent my personal views and do not represent the views of the surgery department or the University of Louisville. Gene?
This is Eugene Shively. I'm a retired general surgeon from Campbellsville, Kentucky. After my residency at U of L, I spent my whole career in rural surgery in Campbellsville, my hometown. What I say doesn't represent that of the Taylor Regional Hospital nor the University of Louisville Department of Surgery.
Our topic today is artificial intelligence in healthcare, something which I confess I really didn't have much awareness of until I started getting into this, so I could ask some intelligent questions during this program. And we have a special guest who's going to help us understand all of the issues related to this. Don Henderson is a doctor of hospital administration, a member of the faculty at Lake Erie College of Osteopathic Medicine in Bradenton, Florida. And he's done 3 previous programs with us, 2 on rural health and rural hospitals and 1 on private equity and healthcare. So, Don, thank you for your willingness to come on and talk about this, what I consider a really fascinating issue, and the changes that this is going to present or produce in healthcare, I think are really astonishing. So we're going to get started. As we've done with previous guests, we're going to give you an opportunity to make whatever comments you'd like to make for as long as you'd like to make them, and then the conversation will begin with Gene. So, Don, the floor is yours.
Well, thank you so much for having me on the program today, and I also want to do the traditional disclaimer, which is that I work for the Lake Erie College of Osteopathic Medicine, and my opinions and views today just represent my own and do not represent the institution that I work for. I thought it might be a good idea to just start talking about and answering the question of what is artificial intelligence. Is it okay for me to just take a couple of minutes and explain that?
Yes, please. That was one of that would have been my first question to you if you hadn't already done that, is to and do this in a way in layman's terms so that our listeners will understand and get an idea what we're going to be talking about for the rest of the program.
Right. So we have a graduate school down here at the medical college that teaches healthcare administration, but we also have several courses relating to artificial intelligence. So it's something that I also have been learning about as we go forward. But the definition of artificial intelligence is a technology that enables computers and machines to simulate human learning, comprehension, problem solving, and decision making. And so one of the things that the viewers may not realize is that AI has evolved to the point where applications and devices equipped with AI can actually see and identify objects, and they can understand and respond to human language. They can learn from new information and experiences. They can make detailed recommendations, and they can act independently, replacing the need for human intelligence or intervention. For example, you all have probably been seeing these shows on the self-driving cars that use AI. One of the things that the viewers may not realize is that AI has been really worked on for almost 40 years now, and it actually goes back even further than that. It pretty much parallels the computer age. But you go back to the antecedents of AI, and you've got telemedicine, which has been used since the 1950s. You've got remote monitoring that's been used in the space program to monitor the health signs of astronauts, and now telemedicine is being augmented by AI remote monitoring of patient wearable devices. I'll just make one more comment, and then I'll open it for some questions. The most exciting part of AI right now is what they call generative AI. It's also known as chatbots, and it's also known as large language models. That's where all of the sizzle is with the steak right now. And what the large language models do is they use natural language processing in order to simulate human conversations. They are not human, and they act like humans, but they're not really human. They're just really repeating what they've been taught in a very sophisticated way. But the chatbots are trained by a process where a large amount of data are fed into the bots and retained for future retrieval. And some of the best known of these chatbots are ChatGPT, which I think you guys mentioned before the broadcast, Google Genesis, and Microsoft Copilot. That right now they have about 60% of the market, but of course the race is on with many other people trying to get into the field. So I'll stop at that point and see what questions you might have.
Don, can you give us kind of a brief survey of how AI is being used in medicine, and then maybe we can get into a little bit more detail of how that's done?
Sure. Well, there's a lot of areas in medicine that AI is being applied in, and I like to think of AI as sort of like a computer. In other words, there are applications that AI is running, almost kind of like the programs you used to load in your computer. So we'll talk about some of the main applications. The one that's the most exciting is what we refer to as assisting clinical decision making. And there have been versions of this for several years now. Most of the people that are clinicians in the audience are familiar with Up to Date and Hippocrates. There's a brand new clinical decision making tool that just came out called Open Evidence. And the difference between Open Evidence and these previous generations are that it basically uses reputable sources, the Journal of the American Medical Association and that sort of thing. So the chat GPTs are starting with basic knowledge, but now it's becoming more sophisticated in evidence-based medicine. We could talk about gastroenterology. AI can improve the process of identifying adenoma detection rates, which is a key indicator of colonoscopy quality. We could talk about radiology, where AI is being used to interpret imaging studies and noting irregularities. We could talk about pathology. We could talk about research. It's being used in research to speed up the research process. We could talk about the streamlining physicians' offices and medical practices. And we could talk about the wearable devices. All of those are areas which we could spend more than the time that we have today talking about them. So you pick which one is interesting to you, and we'll chat more about it.
Well, Don, let's start with the radiology and imaging studies. From what I've learned about this in my research activities for this program is that the accuracy of reading CT scans and mammograms is really improved a lot. Now, it doesn't replace the radiologist, but it certainly increases the accuracy rate by picking up things that the artificial intelligence recognizes, but the radiologist may not. Can you expand on that a little bit?
Yes, I'm certainly not an expert, but I do understand how it works. And what is really interesting is as these machines are learning, or as these AI programs are learning, they always detect the anomaly, right? So in the case of a mammography, the anomaly might not be visible to the human eye, but because they've been trained so well that there was a small breast node, whereas a human being might miss it, they flag it. And that's their role right at the present time, is to be sort of a helpful digital assistant to the people that are actually reading these studies. One of the interesting things we talk about in our graduate school is who is to blame if there's a mistake, because you obviously can't hold the chatbot liable if there's a mistake. It's human beings and medical providers, doctors and others. They're always going to be holding the bag as far as the responsibility to make the final decision. But because they are so able to see and read these studies, they also can screen through a lot of studies because things are digitalized right now. Obviously, radiology has been digital for a while. Gastroenterology is digitalized. And even pathology slides are now being digitalized. So anywhere you've got a digital image, you can train the chatbot to really take a good look at it and identify any anomalies.
I was interested in what you said about gastroenterology. Are you saying that if a doctor is doing a colonoscopy and he sees a polyp, you can take a picture of it while you're doing the colonoscopy, and AI will tell you if that polyp is suspicious or not?
Yeah, there's a version of that, and what happens is, as you know, the physician is recording the examination in real time while they're doing the colonoscopy. So the AI entity is sort of like your little friend sitting on your shoulder. It's also watching the procedure, and if it sees an area that it identifies as abnormal, it will put a green box around the area. It will help you identify that this could be something unusual. And of course, the physician can't stay there forever. The patient's under anesthesia. They got to get these colonoscopies done. So it can even go back after the procedure is over and take a look at the whole study. But the main thing is it's a real-time sort of little gremlin sitting on your shoulder to identify polyps and other abnormalities as the procedure occurs.
Now, Don, how does that work? Is there something, aside from the gremlin sitting on your shoulder, is there something attached to the endoscope that's doing the colonoscopy that's also looking? I mean, how do you get the AI involved in the process?
It's there in real time, and it's looking at the same thing that where you're looking through the scope as the colonoscopy guy or lady. It's there with you, and it flags anything that it sees that is suspicious in real time.
No, I understand that, but I'm trying to figure out: is it something that's new attached to the scope, or is it? I'm trying to figure out how that.
Yeah, definitely, it's a computer program that runs simultaneously with what you're doing. But you're exploring the limits of my knowledge at that point. You guys got to call in a colonoscopy guy. And figure that out.
I think the new scopes are it's integrated into the system.
Well, that's what I was trying to figure out. Okay, good.
Now, so will this AI tell the colonoscopist that hey, you need to take a biopsy of this?
That's a question outside my level of expertise, but it will definitely flag it. It will definitely flag it. I would assume, and if you ignore it and you don't do anything, that's one of the things that happens a lot with the AI computer programs that are running in hospitals. Is when do you want to do the stop? When do you want to do the red flag? In hospitals, if you try to order a medication that's contraindicated, some hospitals allow physicians to do that, but other ones will stop the recording of the documentation until that's resolved. So that I don't think the GI programs stop the procedure, but they will certainly put a red flag, or in this case, a green box, on what's happening.
Well, that could certainly create a problem with medical malpractice. You say you're doing an endoscopy, yeah, and surgeons do a lot of endoscopy, particularly in Kentucky. University of Louisville was one of the first surgery programs in the world to start endoscopy. We started in the early 70s. So if AI tells you you need to do something about this lesion or this polyp, and you don't biopsy it, or you don't do something, and then the patient shows up 2 years later with a colon cancer, then I think puts you in a very precarious position.
Well, hopefully we'll get to that point. I mean, once again, the liability is always with the practitioner, at least at this point. That may change in the future.
Now, there's a wearable device that I was listening to a podcast about. It just seemed to have a remarkable amount of ability to measure things, chemicals, temperature, blood pressure, and pulse. Can you kind of expand a little bit upon that? I don't want to take you out of your comfort zone, but I was just trying to figure out. It's like I guess like one of the watches you can wear, or something you can attach to your skin,
Yeah.
and it gets an incredible amount of information,
Yeah.
which
So-
is available for diagnostic work and
I'm-
management.
Yeah, I'm more familiar with the ones that are used in hospital settings, and the one that I'm generally familiar with is called Hexaskin. But what it is almost like putting on a life vest. I had this idea on my own maybe 10 or 15 years ago, and obviously I never did anything about it, which is my regret. But anyway, this Hexaskin can actually be used by firefighters and policemen, and it's not really widely adopted in the healthcare field, like healthcare at home, but it can monitor everything that you just mentioned, Doc, and it can bring real-time data and look at all of that. And the interesting thing about those AI-enabled patient wearables is it can also monitor the oxygen saturation levels, and not as a clinician, but as somebody familiar with intensive care. If the oxygenation level on the patient starts to fall, that can be tracked and trended by the AI, and you might be able to intervene and stop the patient from having a seizure or a medical event. So a lot of stuff happening. The Hexaskin itself is very expensive, by several $1,000s. So it's used primarily in firefighting, for when the fire folks have to go into like an open fire raging situation. But it's also very expensive, so I don't know how widely adopted it's going to be until the cost comes.
Well, I can do a lot of that with my Apple Watch. I've got atrial fib, and I can monitor it. Right now I can do it, and see if I get a tracing, see if I'm back in atrial fib, and see what my rhythm is. I can also measure my O2 sat, that's oxygen level, and I can measure the number of steps and the number that I've taken in a day's time, and the number of steps that I've climbed every day. So, and then they've got some now that will measure blood pressure, and I don't understand exactly how they do that, but it is available.
Yeah, and I think the question, though, Doctor, is, I read something recently that said that 30% of all of the data stored in the world is medical data, right? So you can have all that stuff being monitored, but then the question is that who is going to do something with that, and who has the time and the resources to do it? Because, self-monitoring, sure, you can do it, but then the question is, if you get a medical grade intervention, how does that get to a provider, and is the provider going to stop what they're doing? The physicians and nurses are very busy. So I think the dilemma is not that we don't have the data. The dilemma is, what are we going to do with the data, and who's going to pay for somebody to monitor and treat patients based on the data that we collect?
Well, there's another option, which I thought was very interesting, which I guess is a microphone that would be in the office, and then you have a provider and a patient, and they're interacting, and instead of having the physician sitting down typing a note, looking at a computer, he's interacting with the patient. The microphone is listening to this and creates a note, which the provider then can look at later on or shortly afterward and make adjustments if they need to. So again, to my understanding, Don, that is just a microphone that's attached to a computer that's in the room.
You take your cell phone and you attach it to your medical records, and it produces a nice office visit or an H&P if you need it. We have 2 physicians been doing that for quite a while, and now we've extended that to all our hospitalists. And one of our hospitalists, which I know real well, she is a real expert at computers, and been one of the first in Lexington to ever start using electronic medical records. And she's been doing it for about 2 months and really likes it. And you're getting a really good history and physicals coming from it. So that is something that's already happening. One of our medical oncologists is also using it and seems to be very happy with it.
Yeah, I think the real issue for, because my wife is a primary care nurse practitioner and she uses the AI capabilities to, it's like they call them a medical scribe because it's very similar to what scribes used to do for doctors in some situations. But I think the big issue for the quality of life for medical providers is what they call pajama time, where you have to spend time either in the office or after hours. Many times primary care caregivers have to spend hours at home or hours in an office getting all their notes into an acceptable format. So if it can streamline the process, I think there's a lot of widespread adoption occurring in that area.
Now, it's my understanding when this note is produced, the provider has the option of reviewing it and making whatever adjustments that they feel is appropriate. Is that's a fair statement?
Yes, absolutely. And it's just an automation of a process that's already occurred, because back in the day, I know you guys are both surgeons, so you had to do your op note. You waited until after the procedure was done, and then you got your operating note, and then you modified that as you thought to capture everything. And that we started with that being handwritten. Then of course there were programs like Dragon that enabled you guys to do that, dictate that. But now it's fully automated with AI capturing it. And my wife, when she uses it, there's some things that go on in the office that don't need to be in the final record, so she'll do some editing on it. But it does a pretty good job of capturing the gist of the conversation, and then also helping remind the practitioners what actually occurred during the encounter.
Well, let us don't forget, though, a lot of people, young people don't know about this, but we used to be able to dictate op notes and history and physicals and progress notes, and you can mumble, and it would come out incredibly very good. I was always amazed that the people who were doing the transcriptions were how good they were. I was recently destroying some old records that I had, and I was looking at some of the H&Ps, and they were about usually 2 pages. And I could look at them within 2 or 3 minutes, could evaluate what was wrong with that patient and what their significant past history was and what I was going to do. Now, if I look at an electronic medical record, it takes me a long time to figure out what's going on.
No, is that because there's so much more information in there?
That's part of it, and then you have to go to different places, and some of the information is, not important, and there's too much information.
Well, Don, one of the podcasts I listened to brought up an issue about the I'm not sure how to put this. The artificial intelligence gets its information from huge databases, and if you have a huge database that mostly deals with the white population, that then applying that to a black population or a Hispanic population creates some issues. And again, I'm asking about this because I don't have any personal experience with it. I'm just learning about these things. And
Well, yeah, let's talk about the broader topic of what can go wrong with AI.
okay, good. That's where
Yeah, let's
going.
talk. I'll kind of cover what you're mentioning generally, but yeah, the one thing about AI which most people don't understand is that it's not always a great decision maker. It doesn't always get everything right. I was going to mention that I think about 65% of primary care doctors in the latest survey will use the chat feature, and so it is useful. But let's talk about some of the things that can go wrong. First of all, chatbots and AI cannot recognize, in most cases, recognize or react to human emotions, and so they may come across as sort of mechanical, and especially with cultural factors, they could insult people, and you don't want that. It's obviously in patient care, you don't want to do that. Chatbots may struggle to understand slang or unusual terminology. There's the question of data security and privacy, because as you say, these are large language models that get a lot of information from a lot of different places. And how do you safeguard patient confidentiality and privacy? I'm not quite sure we figured that part out yet, because this is all so new. One of the things that universities are doing, and including the own university I work for, is they are developing, rather than using an off-the-shelf product like ChatGPT, they're developing their own in-house chatbot. So what that enables them to do then is have a greater degree of confidence that, and they are not connected. You would think, oh, you'll connect to the outside world. They're not connected in any way to any of the outside vendors for security and privacy. Chatbots can create deep fakes, spread misinformation, and damage reputations. So if they're in the hands of bad actors, I think you've seen some news recently about how chatbots are being used in a harmful way. Getting to the topic that you mentioned, they can show bias and inaccuracies based on the data used to educate the bot. There are many different variables in local populations, some of which you've mentioned, but many others. And the bot, if it's been educated in one part of the country or with one demographic and one culture, it could easily not be extendable to other demographics. And that would also even be an international question, for international use of these chatbots. And the final thing, which is not well understood, is that chatbots can have hallucinations. And I was like, what is that? But the chatbots can make things up. And we occasionally will use these AIs to help us in our research at the university. But I saw this myself, and my jaw hit the floor, because it wants to be helpful. It wants to help you, but it sometimes makes up things, and it will make up authors and articles in research databases that don't exist. It'll quote.
Oh no.
It'll quote an article, and it will give you the citation for the article, and then when you try to look up the article, it doesn't exist. So they call that a hallucination. So there are many ways that the chatbots and AI can be wrong. Hopefully, all that's going to be addressed over time, but especially from a clinical sense, you cannot take this information to the bank. One doctor said that AI chatbots are hasty and ill-informed medical decision makers. So take that take that as you will.
That's very extremely serious that they make up references. I I had no idea they did that.
Gene, if you understand how AI comes about as far as programming, currently it's in its infancy, which is a little bit scary. But as you know, you have to think of the AI software learning as a toddler, and they're very bright toddlers, but sometimes they will tend to exaggerate or make up a story, and that's exactly what's taking place here with software.
Wow.
Yeah, well, that brings us to another aspect of this, Don, and I'm not sure where you are with this, and I'm asking this question out of absolute ignorance, but I think it's an important issue, and the question is, what are the kind of medical legal issues related to the use of artificial intelligence? There was one podcast I listened to, and which I thought was very insightful, and they were calling it augmented intelligence as opposed to artificial intelligence, which I think was an important distinction, because it was not a replacement but an addition to the clinical issues that they're dealing with, whether it was in radiology or in an office practice or whatever. But anyway, what are your thoughts about how does, again, some of the things that Paul just brought up about, and you brought up about hallucinations. So how does this fit into the medical legal situation that we live in this country?
Well, I think that, you're exactly right. This is an assistant, right? So, in the past,
yes.
Doctors have always had human assistants, right? You've had nurses, you've had medical office assistants, medical technicians. So, it's just, healthcare is always delivered by a team, at least in the hospitals where I worked for 40 years. Hospitals were a team, a multidisciplinary team. The physician obviously is the leader in many cases of the medical effort, but healthcare doesn't occur without a really qualified and exceptionally talented team. And so I would call the AI a team member. But when it comes to medical liability, it's a shared responsibility. There's the physician that's directly involved, but there's also what they call respondeat superior, which means that even the health system or your employer is at risk. If the physician works for a health system or a university, everyone is at risk. But ultimately, it still gets back to the practitioner. They are the captain of the ship, and the responsibility starts with them. And if you have one more member of the team that happens to be an intelligent robot, you're still going to carry the responsibility.
That's exactly, it's a similar parallel. I'm the proud owner of a Tesla, and currently my Tesla drives me everywhere, approximately, I'd say, in the high 90%, and it's getting better all the time. Every time it releases a full self-driving software update, it's better. Immediately, as soon as you get in the car and you start another trip, you can tell that it's made another improvement. And but people always say, well, can you go to sleep, take a nap? And well, no, you can't. You're responsible for that car legally if it gets in an accident. So that's a very similar situation to what you're describing right now.
Now, are there examples of issues that have occurred related to the use of medical legal issues, malpractice issues, that you could maybe discuss? I mean, I'm asking this question out of ignorance, that have to do with using augmented intelligence or artificial intelligence and having something not work out correctly, whether it's missing something on a colonoscopy or not seeing something on an imaging study, or whatever.
Yeah, I'm not familiar with any cases. I'm sure attorneys in the legal system always finds new avenues, but I'm not aware of anything. I think, though, my biggest concern, as somebody who has at least studied AI for the last couple of years, is data security and data privacy, what they call protected health information, because it is what's happening. You know, a couple of things are happening at the same time. You know, the AI is getting patient data and looking at patient data. But the other thing is that there's an exchange of patient data, patient information that is now going on, which has never occurred before. There's a new law called TEFCA that is trying to encourage all the providers to network their computers together. With AI, this is going to certainly be possible. In Europe, for example, all the pharmacies, all the hospitals, all the medical practices, they're already linked together, so that if you go anywhere, for example, in Sweden, if you go anywhere in Sweden, there are rural areas of Sweden where there's only a few thousand people, but yet that medical record travels with you. And I do see that happening in the United States. But as far as a liability is concerned, you know, that's going to improve the quality of medicine because that information is going to be valuable. But as far as the liability is, if that protected information gets in the wrong hands, the laws on what they call HIPAA, which is the Healthcare Information Protection Act, that goes back at least 15 years. It was written for an analog world. It wasn't written for a digital world, and the information is moving faster than the regulations can keep up with it. That's my biggest concern right now.
Let me just change the subject here for a minute. What about personalized medicine, particularly in genomics and medical oncology? It's my understanding that with the help of AI, if you have a rare cancer, they can analyze this cancer, and the AI can come up with the best chemotherapy and the best drug to treat the patient, and they can identify complications and those kind of things.
Yeah, the one I'm familiar with most is IBM Watson, and I think it's now called. They always wondered for many years what to do with Watson, and I know it has many applications, but it's now actually called. They've rebranded it. Call it Watson for Health. And there is a way, if you integrate all of your medical records into Watson, where if you're doing oncology diagnosis and treatment, it can actually do what you said, which is to pinpoint very rare cancers in certain patients, and it can also use the other data, because what it is, it's not just an imaging study it's looking at. It has the whole data picture of the entire medical record of the patient, and then it compares and uses that algorithm to make a recommendation. One more comment I wanted to make is I recently saw a presentation from a pediatrician at Harvard who said that he had a child. He's a pediatrician who's dealing with children. He had a child that had a very rare disease, and he loaded all the parameters in the AI, and it immediately identified a very rare pediatric neuromuscular disease that was almost unheard of. And he said if it wasn't for the AI, they wouldn't have caught that. So it's kind of interesting.
Well, I just did that this weekend. I put a patient that I had in the past, put the information in on my cell phone, and the chat GPT came up with a diagnosis immediately. I mean, it was kind of an uncommon problem. I was very, very impressed. And then it described, to confirm the diagnosis, it described what CT scans need to be done, and then what needed to be done for the diagnosis. It was very impressive.
My wife tells me, she works in a primary care office. She tells me that the patients are feeding their own symptoms into AI, and then they're going to their doctor with a paper in hand, saying, "Well, I've checked with AI, and they say this. What do you say?"
Well, I'm still seeing in-home patients for a company called Signify Health, and over the years that I've practiced, patients know lots more about their illnesses and the drugs they're taking, It's very impressive what they're getting off the internet. And these are not just sophisticated patients. I'm not talking about patients with college degrees or postgraduate degrees, but I'm talking about patients with who don't even have high school diplomas. So it's very, very interesting. And the real problem is now if somebody comes in with that kind of information, then you're going to have to at least what I would have to do is have to prove they're either right or wrong, and then that gets into more complications. Usually ends up with more tests to prove if you're right or wrong. For example, this is something that always was a problem for me in practice. Somebody comes in with irritable bowel syndrome, and clinically you could be 90% sure that was what was wrong. But if a patient wasn't convinced, then you end up doing CAT scans in order to prove that all they had was irritable bowel syndrome, which can be very distressing to some patients. So this brings up another issue, which really the main purpose of this program and these series of programs is how is this going to affect the cost of medicine in the future? Is it going to make it less, which some people say, or is it going to increase cost?
Well, let me let me ask Don, because one of the podcasts I listened to dealt with that, and the discussion was around coding, and one of the consequences of the artificial intelligence involvement in this process was upcoding and the identification of all kinds of medical conditions that may or may not actually be a medical problem to a patient, but they exist. So, Don, can you help us out a little bit with that? And again, I'm asking the question out of ignorance.
Yeah, I think there's no question that if we didn't talk about this much, but there's a lot of things behind the scenes that medical practices are doing. For example, like if you call to make an appointment, the chatbot can make you an appointment in some practices, and they can answer basic questions, non-medical questions you might have. So could a billing and coding AI assistant help you capture all of the codes that you want to capture? I would say yes, but it's any kind of upcoding is illegal. So you have to be really careful to have a human being review that record to make sure that it's being billed and coded appropriately.
Well, the Medicare Advantage plans make their money from upcoding. They've turned that into an art form.
Well, not all upcoding is illegal. I mean, a lot of it is legitimate, but it's not important. Again,
I didn't say it was illegal. I mean,
no, but
I don't know that it made an effect on the patient's well-being to just identify all of these kind of relatively minor things that are going on and what you can charge for, which is what the Medicare Advantage plans have done.
Yeah, let me give you a classic example of that. You got a patient who's diabetic. Let's say they're 75 years old, okay? And the Medicaid Advantage gets paid a certain amount for taking care of that patient and their diabetes. Well, if you can prove that they have peripheral vascular disease, then you can dramatically increase the amount of money that you're going to get paid for taking care of that patient. So all you have to do is do either an ultrasound or an ABI, and let's say that they have mild peripheral vascular disease. They have mild obstruction of the femoral vessel. Now, they do have peripheral vascular disease, which is legitimate, but by by putting that on the chart and coding that, they dramatically increase the amount of money they get, and that's what's going on. And it's a legitimate disease, but it's not a disease at this present time that's going to affect the patient. And that happens on multiple occasions, and they're dramatically increasing their reimbursement from the federal government through the Medicare program.
Yes, and that was the issue with the medical or the artificial intelligence identifying all of these issues, medical issues that really weren't having any impact on the well-being of that individual. So, Don, where does all this go? I mean, is that something that can be managed, or is it just something you just have to live with?
Well, again, remember, all of these rules and regulations were developed for humans, right? They were developed based on a human being doing the coding, human being then turning back to the practitioner, because the practitioner ultimately is responsible for the codes. So, yeah, it's just what I talked about earlier with all this accelerating information. The regulatory side is going to have to catch up with the digital side, and right now the digital side is winning. And like you said, it may result in unnecessary reimbursement. So it's going to be a chicken and an egg kind of thing. And I think that one of the things is that regulators are going to have to address all these issues with the liability, the too much information in some cases. All these things are going to have to be addressed as we go forward.
Now, how do you address that, though? I mean, if you're using this as a coding device, and you take the example that Gene just gave us, somebody with diabetes who has a mild degree of peripheral vascular disease that's not having any effect on their well-being or their activity level, but it becomes part of the record and then becomes a reimbursement issue.
Well, I've got a good example. When I was a hospital administrator, we were paid, hospitals were paid on these diagnosis-related groupings. As physicians are paid on what's called CPT codes. But people got better and better in the hospital field of identifying, they call them comorbidities and complicating situations, and we got better and better at it. Medicare just made a rule one year. We got this notice from Medicare, hey, we're going to pay you 2%. We're going to take your previous rates and just take 2% off the top because we know you've been upcoding. And they just made a rule, and so we all got 98% of what we were getting before. So I think there are general ways of dealing with it, but I don't really think I have the answer that you're looking for as to how to regulate all this. I don't have the answer today.
Well, we need to realize now that most coding is done off-site or not by doctors. For example, most hospitals are outsourcing coding. And I have a friend who works for a major university, and he told me that doctors should not be coding anyway. They have a large group of technicians and nurses who do all the coding for them. Now, the other problem is if you're in a field like general surgery or family practice where you're doing a lot of different things, it's almost impossible to keep up with those codes. Now, if you're in a field where you're just doing a very high specialty, it's probably easy and the doctor can do the coding. And doctors probably should be doing the coding, but there's only 24 hours in the day, and it's hard to keep up with all the codings, particularly when they keep changing. I about 20 years ago used to go to coding classes, and I go to a class, and my wife, who's a nurse practitioner, would go with me, and we thought we had it down, and then 6 months to a year later, we'd go another coding class, and they'd change the codes. So I decided I'm not going to waste my time doing this. My job is to take care of patients.
Well, let's switch horses a little bit here. And again, I'm going to make this comment out of ignorance. one of the things I looked into was the use of artificial intelligence in robotic surgery, and it was fascinating. Apparently, there are 4 or 5 levels of this, and in the current situation, there's some artificial intelligence in that as an assistant to the surgeon doing the robotic surgery, and then there's this other extension of this where the robot essentially does it by itself without any human interaction. Don, is that something that you've got any awareness of? And like as I said before, I'm making these comments out of ignorance because I don't have any personal experience.
Yeah, I think you could. Well, I mean, remember, in a regular surgical case, you have what they call RN first assist. They call them RINFAs, and the RINFAs, suture up the patient. Usually the surgeon doesn't close, or maybe you guys did, but normally these days the surgeon's getting ready for another procedure, and the RINFAs or the surgical techs actually close the incision site. So yeah, I could envision where that might be replaced by a robot that would do certain tasks. Again, if you think of the robot being sort of like a human assistant, you can. I'm more familiar with the robots basically being an extension of the physician's actual hands. Because on the Da Vinci system, there's these little paddles that they use to do microsurgery or to do surgery that is through 3 or 4 different scopes and incisions that go into the patient without having to open the patient up. It's interesting because in my experience, they use that a lot in general surgery and in urology. It never really cracked open in cardiac surgery because it increased the pump time and it increased the time that the patient had to be under anesthesia, which was a risk in and of itself. So, yeah, could you envision a day where this could be more of a physical, an assistant, and some of the procedures could be done like tying a suture or something like that? Yeah, you could envision that, but I'm not aware of it at the present time.
Well, it's been done on animals. They've done, for example, cholecystectomy on pigs without the surgeon being involved at all, and supposedly the pig did well.
Well, I'm glad to hear that, Gene.
So I think that's coming. I've been told. I've never done robotic surgery, but we're doing it here, and I think we're going to see almost all surgeons trained to do that. But the robot will tell you you're getting too close to the common duct, or there's a vessel here. You need to be careful. You don't want to injure that vessel, or the ureter's here. That kind of thing, I think, is going to be helpful.
Well, that's kind of my understanding. Is that's kind of where we are today with that with the robot. The other question is, and I don't know about the pig that you were talking about that got operated on. I'm just kind of curious how the surgeon is going to be out in the lounge smoking a cigarette while all this stuff is going on.
Okay, well, I have to get back to my Tesla now. It's the same thing, yeah. I long for the day when I can crawl in the back seat and take a nap.
While the car's driving?
Yeah, but I can't do that yet.
Well, I hope not. I don't want to be on the road when you're doing that, sleeping in the back seat.
Well, it's all very interesting, and I think it's going to make a profound effect on medicine, and it's probably going to make a huge effect on patient care, particularly in fields like radiology, pathology, and and particularly oncology.
Well, I think it's already done that, and especially in radiology and pathology as well. Apparently, the artificial intelligence can look at the slides and often see things that the physician who's looking at them may not recognize. In a similar way, looking at skin lesions and evaluating these lesions that might be melanoma, and they're putting together the different aspects of an abnormal-looking skin lesion. So, I guess the question is, how far does it? That's my concern. Is how far does it go when you've got the robot doing the pig's cholecystectomy? I'm just not sure how that's going to work.
There is an app you can put on your cell phone right now. You take a picture of a skin lesion, and it will tell you what it is. And supposedly, I haven't read the papers or looked at the data, it is as accurate as a group of dermatologists in making the diagnosis.
No, that's my understanding. That's the same thing. That it's very good about doing that.
One thing to keep in mind though, and again getting back to the subject of single payer radio, one of my big fears is data security and privacy. I already mentioned that, but my other fear is what they call the digital divide, which is where people that don't have insurance, that don't have access to the medical system, because as you think about it, you've got patients that are not getting access to medical care now. You have patients that are still uninsured. In Florida, it's a big issue, and it's been made worse by the fact that they canceled all of the Obamacare subsidies. So, a lot of wonderful things are happening with AI in medicine, but you have to be able to have your ticket to get into the system. Otherwise, you're never going to get into the big tent and have all these miraculous things happen for you. So I am concerned about.
Okay, guys, I'm going to give you the 2-minute warning. Don will give you an opportunity to make whatever comments you'd like to make, and then Paul's going to take us out.
Yeah, well, I'd like to thank everybody for having me on today. I think we've covered a lot of interesting topics. I think there's no question that AI is going to be a big player in the future of medicine. I hope that the human factor is always going to be there, that there's always a physician or a provider that's there and takes the responsibility. And we pointed out earlier that AI is still not very humanistic, and so it can't really replace the human-to-human interaction, not at least at this point. So I'm hoping that we can maintain the best aspects of the previous system that we were working in, and then use AI as a helpful assistant in the future.
And Don, thank you again for coming on. You're a great guest.
And I would like to thank you, Dr. Flynn, Dr. Shively, and Dr. Henderson for providing today's program. And a special thanks to our listeners for tuning in. If you'd like more information on single-payer healthcare, please visit our website on kentuckyhealthcare.org. This is Paul Hoppe with Kentuckians for Single Payer Healthcare and Forward Radio at WFMP 106.5, inviting you to listen to more of the many diverse programs that we broadcast here on the station, and wishing you a wonderful rest of your day.